Thanks for that introduction. Good afternoon. Thank you for the opportunity to present today. Thank you. All authors have nothing to disclose. So inguinal hernia repairs are one of the most commonly performed surgical procedures. There's over 20 million done annually, and 800,000 of those are done in the United States alone. So globally, the incidence of hernia has increased by 64% in the last 3 decades and is now in the highest in patients between the age 50 to 69. And the combination of a globally aging population and increasing rates of obesity helps drive this continued rise in inguinal hernia prevalence worldwide. So there are many different techniques for hernia repair, but regardless of technique, chronic postoperative pain is the most frequently reported complication now, and its management remains a significant challenge. So up to 18% of patients suffer from pain after an open inguinal hernia repair, and up to 6% of patients after a laparoscopic repair. This progresses to significant chronic pain in about 0.5 to 6% of patients, which is defined as debilitating pain lasting more than 3 months with moderate to severe impact on normal daily activities or work. So, however, the diagnosis of chronic pain related to hernia surgery compared to other mechanisms and pain syndromes is challenging to study due to its highly variable and subjective nature amongst patients. So to better understand and improve patient outcomes, the European Registry for Abdominal Wall Hernias was created in 2012, and this database helps standardize the reporting of patient and pain outcomes after inguinal hernia surgery. Specifically, there's a quality of life tool that we looked at that includes a pre- and post-operative question to assess pain, restrictions, and cosmetic satisfaction. So each point is scored on a 10-point Likert scale, with 10 being the worst pain imaginable, so higher pains decrease satisfaction. But even with this development, the etiology and risk factors for dissatisfaction after inguinal hernia surgery remains poorly understood. Additional barriers to identifying risk factors include the variability in indications for surgery, practices in preoperative care, and operative technique. So to address these issues, the Abdominal Core Health Quality Collaborative, the ACHQC, was developed in 2013, which includes a lot more information. So our question was, using this quality of life tool with this database, what are the risk factors for increased pain after unilateral inguinal hernia surgery? So we included patients undergoing elective unilateral inguinal hernia repair from March of 2019 to May of 2023. We excluded patients who underwent a ventral hernia repair as well, had intraoperative complications, who had non-clean wounds, who underwent a hybrid operative approach, or do not have 30-day follow-up. And our total N was 7,460 patients. So we looked at all the variables collected in the database and reviewed them, and we selected variables that were potentially related to inguinal hernia repair outcomes based off of our clinical experience. So this included demographics, social background, including insurance, employment, and sporting activity, medical comorbidities, BMI, ASA class, et cetera, preoperative medication use, as well as hernia factors, size, and the number of defects, as well as perioperative factors. We then completed a multivariable logistic regression to identify factors associated with either high or low scores, and we dichotomized based off the median score, based off the overall quality of life survey tool. So we'll start with overall score, which is going to talk about their overall satisfaction. So with high overall score or less satisfaction compared to male patients, female patients, and those of Black race had higher scores. So employment with heavy labor and a higher ASA class were also associated with poor satisfaction. Conversely, low scores or higher satisfaction was associated with antiplatelet use and intraoperative local anesthesia. Interestingly, having sedation or general anesthesia did not impact overall scores, and those that received a tap block also did not have better outcomes compared with the intraoperative local anesthesia. Finally, there was no difference based off the operative approach, OR time, or history of prior pelvic operation, but a previous mesh placement was associated with worse overall scores. We then looked at the results for pain, and again, female gender and Black race was associated with a higher pain score, so worse pain, as well as Hispanic race. Compared to Medicare and Medicaid, patients with self-pay or private insurance were also more likely to report higher pain. Patients who performed heavy labor tended to report higher postoperative pain, but interestingly, compared to desk-based workers, patients who were retired or unemployed also tended to report higher postoperative pain. With regards to patient comorbidities, higher BMI, diabetes, COPD, as well as preoperative opioid use, both acute, less than 30 days, and chronic opioid use, none of those factors significantly impacted postoperative pain. Nicotine use was associated with significant more postoperative pain in patients who were current users, as well as an ASA class 3 or above were also more likely to report worse postoperative pain. The indication for surgery also influenced high pain scores, and those that presented with pain, but without a bulge, also tended to report worse pain after surgery compared to those who underwent surgery for an enlarging hernia without pain preoperatively. Similar to overall score, patients taking an antiplatelet medication reported less postoperative pain. And the type of anesthesias patient underwent, whether general anesthesia or sedation, was not associated with any significant differences. However, again, patients who received local intraoperative anesthesia reported significant less postoperative pain, and again, TAP blocks did not improve pain scores. Finally, patients with larger hernia defects, so 1.5 to 3 centimeters, also reported less postoperative pain. So what are we going to do with all this information? Our study utilizing this database is one of the most comprehensive hernia outcome registries. It reveals several interesting characteristics associated with increased or decreased satisfaction as well as pain. So we found gender disparities and racial disparities in both pain control and overall satisfaction, which unfortunately has been previously described in the literature, although the etiology is not well understood. Additionally, in terms of medical comorbidities, we had overall scores and pain scores improved on patients with chronic antiplatelet agents. And these are known to reduce inflammatory markers and inflammation, which could play a role in mediating postoperative pain. But again, the etiology is not really understood. In contrast, nicotine and cigarette smoking are known to be pro-inflammatory, which cause vasoconstriction and impair wound healing. So this correlates with a higher pain score, which we also found in our studies. One of the greatest predictors of poor patient satisfaction and pain was a higher ASA class. So additionally, patients who are employed with performing heavy physical labor tended to report worse outcomes overall, as well as worse postoperative pain. While both of these are not easily modifiable risk factors, this may help clinicians set more realistic post-op expectations and enhance the risk-benefit discussions, as well as return to work precautions. There are also several strong associations between the indication for surgery and postoperative outcome. So patients who presented, again, with pain before surgery or who had chronic pain after a prior repair had significantly higher post-op pain scores. And this relationship between the pre- and post-op symptomatology has been well studied in the literature. So preoperative pain strongly predicts postoperative pain, supporting our findings. Finally, patients presenting with the large defects also appeared to have better postoperative results. So compared with patients who had hernias less than 1.5 centimeters, the hernias between 1.5 to 3 centimeters had better overall pain and outcomes. One interpretation could be that the larger defects are more symptomatic prior to surgery, and therefore patients experience a greater relief after repair. Interestingly, on our conclusions, there's nor recent nor chronic opioid use was significantly associated with postoperative pain. This could be due to teams, maximizing non-narcotic pain medication use. I think this has been a highlight in lots of people's practices. We set clear expectations about post-op pain with these patients and create a pain management plan preoperatively in conjunction with the patient's chronic pain provider. So overall, our study highlights several risk factors that can, broadly be characterized into modifiable and non-modifiable patient and procedural factors. So race, physicality of employment, and reoperation for pain after a prior inguinal hernia surgery are risk factors for higher post-op pain. Chronic antiplatelet use, absence of nicotine use, and operation for enlarging hernias and a larger defect also decreases the risk for higher post-op pain. So elucidating the etiology of these important disparities is somewhat outside of the scope of this study, but our results suggest that a one-size-fits-all approach to postoperative pain management is probably not appropriate for the diverse patient settings, and hernia surgeons needs to be attentive to the possibility of patient-centered changes in post-op management to better tailor our preoperative risk-benefit discussions. Thank you so much. Thank you.